everyone here. This is one of our multimodality imaging sessions. The topic that was assigned to us was to speak about the calcium score within the context of the power of zero. But as you know, we had multiple prior discussions in this regard as far as the asymptomatic. And if you haven't had a chance, you can always go to our DeBakey Heart and Vascular YouTube channel and look at some of the grand rounds. And as everyone's walking in, I was saying, okay, why don't we expand what we already know in the asymptomatic population? Can we push the envelope out here? And you know, this is mainly, I think so, a discussion for our younger colleagues. I think so in the context of what is evidence? How do you put that together and take into account uncertainty, the trade-offs? Where does guidelines actually fit in? And more importantly, your own and implicit and explicit bias and the challenges for really implementing. So as everyone's settling in, I can tell you that the journey around the power of zero, or the non-contrast CT scan showing no plaque buildups starting in 2019, I think so it's come a long way in spite of the things that, many of the things that you see, especially on the social media, that's been called upon maybe a worthless product, Diet Coke Zero, but I have it with me here, a blind spot, a Pandora box fallacy, and many others. But in spite of the fact that all of this resistance, be it in our own understanding and in general cardiology, non-cardiology community, I think so it stood the test of time. And really, after almost 1,000 citations, publications, it has come over the last many years. It's well established to be a tiebreaker in asymptomatic individuals. And you know, most of us who see patients in clinics, we'll see a lot of conversation around what's your risk? Do you need to be on any treatment or not? And clearly, as you can see with the guidelines in 2019, acknowledging the fact, let me just check, is this mic working? Okay, fine. With the substantial advancement made in the calcium scoring for the first time in 2018 and 19, the guidelines acknowledged the fact that, yes, you may still have no plaque buildup, even if you're considered at high risk. And as Dr. Fuster would say, forget about the statins. This is a test that may you not need a statin by Harlan Cromwell. And it's not only about the statins, and not only the US guidelines. As you can see, a summary of the guidelines, the message has gone all across the globe, be it US, Canadian, UK, Chinese, EU, Australian. The common indications, you know, if you're above age 40 and above, you're somewhere in between, you're uncertain, clearly, but two things are very clear. If you're at one end of the spectrum with the calcium greater than 100, you're pretty high risk. You should all be intensely treated. On the other hand, now it's extremely well established, although there may be some minor controversies in some of the small vocal contrarian groups, but apart from that, there is a general acceptability. Calcium score of zero, pretty low risk. And there are some disagreements. Well, you should be used for aspirin or not, and clearly not only the national guidelines, but the specialty guidelines. So 2019 till now, it's really come a long way where it's becoming part and parcel of our practices. There is less uncertainty, there is more evidence, there is more acceptability, and adoption by the guidelines clearly has helped. So that's great. I think so that's all the lecture was all about. But not really. I think so even if you go from that, we are taking that approach to our clinics too. We have expanded a little bit more. It's not only about the power of zero. It's about presence of calcification and high calcium scores, where clearly if you are calcium greater than 100, we have a checklist approach developed by our fellows, Dr. Taha and Dr. Avanati, that you should be treated someone who has an established cardiovascular disease. And Dr. Patel showed that how even the cardiometabolic medications should be out there for for these individuals. So is everyone able to hear me loud, clear, better? Now? Okay.
I think better now.
Better now. So I have two mics. I'm trying to figure it out which one works. All right, but that's the story where it ends. I think so there is a lot of room for in the asymptomatic word, but truly there is still a big missing piece in the puzzle. And we have to look into the future, and of course, as clinicians who are dealing with not only at one end of the spectrum, which is prevention, where you want to understand who is at risk at an early stage and preemptive. I think so a foundational condition and thing would you in cardiology is coming with patients with symptoms, and how do we make things better? Now, definitely this is a space where, of course, we have, as a team, all across, we have brought the power of zero extensively forward in the asymptomatic world. I truly see there are tremendous opportunities, especially for younger folks, early career who are trying to build, because there are tons of clinical scenarios where we need more clarity and much better pathways. So, but how do you move ahead? How do you plan? I think so. No better than to look at this person. Anyone, I'm sure, any Canadian here? Steve's not here, so Wayne Gretzky, amazing, like thought about as the greatest hockey player ever. Played for 20 years from 1979. A lot of you weren't born by then to 1999. Has the most history of the highest scores and assists. And maybe the only person in the NHL who scored 200 points in one season, 4 times. So pretty good. And when you ask them, okay, fine, what's the secret of your success is, really, I don't know whether he said it or it came, but it's really tied to him that skate to where the puck is going to be, not where it is. And I think so that's always, and the message is very important again for early career folks, where you will be the leaders and leading medicine and innovating and refining and bringing in those transformation in the next 5 to 10 years where the opportunities are. So let's divert to a case that we see in clinics almost every day. Nearly 60-year-old man with elevated lipids, non-smoker, hypertensive, blood pressure controlled, coming in with occasional exertional and at rest chest pain. Pretest probability is intermediate, and considering what do you do next? Now, of course, among better assessment of other risk factors, getting a better sense of the symptoms, this is an imaging conference, but most of the time you're thinking about, okay, does the person has CAD? What's the severity? Is it ischemic? It is obstructive? Yes and no, and how it's going to affect your management. So clearly, if you look at the guidelines, you won't go wrong whatever you choose, right? So depending upon what do you believe more, is it more around imaging athro or looking for perfusion or ischemia, you can go either with a CT-based approach or a stress test. And the good thing is, if you look at the guidelines after many open deliberations and I would say disagreements, where this may be the second or the third version of the chest pain guidelines, where many societies decided maybe not to participate initially, but when in the consensus, you can see almost every imaging modality can be a class 1, but one notable miss is out there is clearly a calcium test. So let's assume you pursue a stress testing approach. Clearly what we know, if you look over the last 30 years, so as a fellow, you can literally sit on the other side of the room and call every stress test that was done in today's days normal, and you would be accurate almost 90% of the time. So that's the reality, and the disease state has changed, the risk factors have changed, the management has changed, so we are not seeing a lot of ischemic heart disease that. Now, if you move to the CT, of course, you get amazing pictures all across. But if you're looking at whether there is underlying disease, at the most of the cohorts would suggest about 10 to 15% may have that, about 30% may have some early plaque disease. Most of the asymptomatic adults, 50% may have it, and about 50% you may come out very cleanly. So now, thank you so much for helping with this. Now I can step back a little. So the question really is, even in the old and the contemporary era, if you and I decide to send that patient for further advanced imaging, be it a stress test or a CT angiogram, if you look at one of the better studies contemporary from the PROMISE, only about 10 to 11% may actually have the disease. Significant enough where you may make a meaningful change. Of course, about 30% may have some early plaque. That's why in younger individuals without established CAD, I tend to prefer CT, and I'm sure most of you would agree. But as I was saying, where the puck is going to be, clearly the puck in the future, apart from precision, apart from population health, I think big data, AI, health equity, I think so a lot of that will also be in the value-based care. So the value-based care is really, you got to do more with less. There are not enough resources, and you want to optimize your yield for every input as much as possible for quality, better outcomes, preferences, and everything else we do. So the question I want all of you to ask, in that setting, can we afford 80 to 90% of our advanced imaging in these scenarios? And I'm sure as fellows, you would see that often being no meaningful CAD. Can we have a better selection of the patients that we send there? Can we do better with clinical pretest probability or other ways? In the end, do we need a gatekeeper mechanism? So that's kind of the thought process. If you believe that there is a waste, and if you believe that we can still do better, then the mechanism of a gatekeeper discussion comes into being. And usually when you start thinking about a gatekeeper mechanism, you want it to be something that's widely available. So it's not like you have to spend more to get that answer. It's economically feasible. It's a straightforward evaluation and safe and accurate. And now when I start putting these characteristics together, and I've always thought about, can power of zero be a solution in this? Of course, almost on the same theme processes we have explored in the past. Can it help decide you're at risk, you need treatment or not? But what about, does my patient, a 60-year-old with intermediate pre-probability test, if I do a calcium score and has a 0, is it all right to safely avoid downstream testing? So that's the question. In all honesty, in 2009, when we first promoted the concept, it wasn't for asymptomatic individuals. The need there was really with new emerging techniques, can we have a gatekeeper mechanism? And based on, now honored to present in front of the Lord of Meta-Analysis, Safi out here, that this was a meta-analysis that we did in 2009 that showed of all the 20 years data, in symptomatic, extremely favorable prognostic value, and a pretty high negative predictive value for ruling out obstructive disease that was mainly cath-based, almost 98 to 99%, a very low prevalence of ischemia and a calcium score of 0, and in limited study at that time, almost only about 430 patients coming to chest pain, the negative predictive value of ruling out ACS was about 99%. Of course, we were extremely bullish about that and came out with our own algorithm in next few years, really trying to promote this concept that, yes, you start with the pretest probability, and if it's in a low to intermediate, maybe start with the calcium testing, and if it's 0, do nothing. And somewhere in between, depending upon how accurate the CT angiograms are with the various calcium scores, you can decide ischemic workup versus anatomical. And again, by the way, this pathway was adopted by the NICE guidelines in UK for 4 years. It was the rule of the land. And they did pretty well, but of course then there was a mild change. So, for me, it was, although the asymptomatic word was easier, this was really the feeling of pushing through this concept of power of zero and asymptomatic, because almost every 6 months I would get an email or a text from a friend or a colleague about a missed obstructive disease, that the risk of calcium score is not minimal, and the most common thing. And I'm sure most of you would share the same sentiment. I'm not comfortable reassuring a patient symptomatic under my care in the hospital, in the ED, or in my clinic if your calcium score is 0. And in fact, many of the leading thought leaders would say, calcium scoring and chest, and it's fantastic, asymptomatic, let's keep it there. It's really dead on arrival with chest pain. Now that's the issue. So look, there are facts, there are beliefs, there are biases. So the first thing is really when we start talking about the risk of CAD, it's not minimal. What does that even mean? Where's the data? So I've shown you the data from prior studies based on cath findings that the negative predictive value around 99 to 98, does it really expand? So where do you start looking at? Of course, in this day and age, you have a lot of CTA studies. So why don't we start there? So one of the best over the last 2 decades, the CONFERENCE study, which multi-center, a true real-world experience, 10,000 patients. And as you see in your clinics or ED and everything, about 16% having an obstructive disease, and about half of these patients have a calcium score of 0. So out of 10,000 patients, and this is no different than what you do in your own clinics or the CTA reads or in the ED, almost half would have. So what is the likelihood that they will have underlying disease? What's the negative predictive value? So if you look at in this study, really the negative predictive value for a 50%, and really the gold standard 70% is 97 to 99%. Of course, in the other context, I will bring it out. It's almost similar or maybe better than a lot of the current modalities which are class 1. But again, one can argue real world, no standardization of bringing these patients in. There's a lot of mixture of patient shortness of breath, pretest probabilities, who knows what. But if you go to the PROMISE study, which was a clinical trial, intermediate to high risk individuals all across recruited, and about 4,000 had calcium testing, and about 4,000 had stress, 4,000 had CTA plus calcium testing, and 4,000 had stress, you almost find the same negative predictive value of almost 98 to 99.5%. So this is what the risk of having an obstructive disease in your patient with a calcium score of 0 who is coming in with stable chest pain. Now, of course, one of the other issues is calcium does not really exclude ischemia. I'm really concerned more about ischemia that is significantly associated with high risk. What about that? So again, how often MPI or even on a PET abnormal you're going to see a calcium score of 0 if the calcium score is 0. So our first study that highlighted in 2009, we had 8 studies, almost 3,700 patients. About 6 to 7% of these patients within the calcium 0 group had ischemia. But by the way, we have no idea it's mild, minimal, what's the outcomes. But again, it's a decent, I would say, a reasonable size for us to be concerned. And even if you add the contemporary data now with a study in 2018-16, now with 20 studies, 7,000 patients, you find almost the same robust data all across the spectrum. Doesn't matter. These are not low intermediate. These are all patients who are getting SPECS and stress-induced myocardial ischemia. So what about PET? I was really surprised to see this study come out literally a couple of months back. Good to see the power of 0 out there, and actually an original study rather than an opinion piece where they really was trying to do with rubidium PET irrespective of sex and age, and I hope that we can try to replicate or even expand this study out here. So this was done in Basel, Switzerland, about 2,600 SPECS, average age of 65. where even in this high-risk group, so when you're sending for somebody for a PET, most likely a high-risk group, about 26% of them had a calcium score of 0. Now, these are the PETs done in Europe, so they are more, I would say, conservative and sending really the high risk. If you look at the negative predictive value for an abnormal PET or more than 10% ischemia, I'm not really sure how you can beat that. So if you're truly interested, if your calcium score is 0, you're almost 100% negative, and especially in the younger group, the negative predictive value drops in the very elderly. About 4% individuals with a calcium score of 0 and a normal scan, and about 2% abnormal scan in females and men. So this is really what it is. But again, how do you put that into context? And for at least coming out from the authors, they are suggesting again almost what I have been suggesting for a while, that it is a suitable gatekeeper before advanced cardiac imaging. I don't think so. Radiation, of course, with PET may be a little higher with the CTAs and not as much. The cost savings are substantial from a society perspective. Of course, you need further studies for endpoints. That's the usual theme that happens. But the question is, what's the risk? So for example, if somebody comes in and has a calcium score first, and then it's 0, and yeah, they may even have an abnormal stress test. What about those 6% who have abnormal stress tests? I'm worried about that. I'm sure you are too. But when you look at studies, and the question really is it safe? And from Alan Rosansky and Dan Berman, from their historic studies, if you look at those with a calcium score of 0, of course, 1.2% had ischemia, maybe a little higher than what we found. Among the 3 patients who were ischemic, of course, we thought that we should take somebody to the cath in less than 60 days, but there is no revascularization. Less than 60, less than 90. There is no MI. The annualized MI coronary death is 0, of course, but again, one can argue this is just 32 months. Look, we just don't do a test and forget it. 3 years reassurance pretty good. But let's take to a larger study coming from Engber's group, 5,000 patients, 91 intermediate risk, 5-year follow-up. There are almost 6.5% MACE. As we showed in 2009, 6% with calcium score of 0 had ischemia, exclusively mild. There's no increased risk with ischemia when calcium score of 0. Actually, numerically better. But again, that's not the point. The point is, again, if you have a calcium score of 0, and even if you have ischemia that's mild, in the next 5 years, there is no event. So you can be pretty much safely reassured. And if you ask like Alan Rosansky and Dan Berman, they'll say that the risk is so low that if you have a calcium score of 0, refer them from any further advanced testing. And Engber's would even go a little ahead and say, with a score of 0, it's can result in unjust invasive imaging with additional cost and complications. So, really a group that we should be thinking about, is there an opportunity for implementation into what we have? But now let's take to the PET in the US reality. Of course, hopefully we'll have some data from our own program, but from Intermountain, where they, among 1,200,000 patients, they excluded those with prior history of CAD, elevated troponin transplant, or died during discharge. You can clearly see almost more than a half of them have a calcium score of 0. So when you, without established disease, if you're doing PET, and I'm on the PET, almost half of them are going to have a calcium score of 0. Now, if you would have introduced it upfront with that $50, my whole take is you could prevent a lot of the PET scans, but is the risk worthwhile? So when they look at less than 90 days outcomes, only about 0.6% of them had a high obstructive disease, 0.5% of them had a revascularization in less than 90 days. And when you're looking at outcomes, the outcomes of MI long-term is about 0.4% and 0.8 double. Now, this is a very interesting slide. I want you to see what's interesting out here. So with a calcium score of 0, majority of your MIs are type 2 MIs. And as we clearly know how the type 2 MIs are classified, anybody who walks in with sepsis and has a troponin elevation or AFib RVR troponin elevation, it's a type 2 MI. And a lot of NSTEMIs are classified, and we've been working very hard on that. Whereas with calcium present majority, it's actually the reverse. So clearly, the basic foundation of ACS, you can clearly see the risk is extremely low, where the authors rightfully suggest that the potential for a calcium first assessment that takes about 5 minutes at the most, and these intermediate risk individuals who would not need coronary revascularization, and there is an opportunity for a layered strategy. So clearly in the PET world, of course, PET is extremely sensitive. You're clearly seeing, of course, one can argue, well, there is a lot of myocardial blood flow abnormalities. In all honest opinion, I think so that's more of diastology and a reflection of diastolic failures or grade 2, whereas yes, they may be a high risk, but when you're talking about CAD, definitely the risk is extremely low. Now, when you look back at the PROMISE data, so one thing is, it's a standard of care, class 1A recommendation. A patient comes in, we do a stress test, we reassure them, we discharge them either from the hospital, from the ED, or from our clinic. And clearly from the PROMISE study, you can say if you have somebody with a normal stress test, in the next 3 to 4 years, your rate of cardiovascular disease, MI, unstable angina, is pretty low. It's almost 1.6 to 1.3%, well within the tolerable rate. But would you have the same reassurance if it was a calcium score of 0? Anyone among you would have. In all honesty, I wouldn't have that reassurance. But why is that? Because when you look at the data, the outcomes are almost 50% better. In the same study, where individuals had a calcium score of 0, almost 50 to a twofold high, lower risk of cardiovascular disease, myocardial infarction, unstable angina. And we should all have more reassurance if our practices are evidence-driven versus our gut feeling and implicit bias. So clearly, Matt Burdoff and Udo Hoffman, Udo was chair of ROMICAT-1, and Matt is suggesting that this is the optimal. And this is based on one of the largest study as an initial test followed by a second test, and that could be whatever your choice based on a high calcium. And it supports the use as a first approach as done in Crescent, and I'll come back on Crescent for further evaluation. But, you can still argue and push back and say, well, this is 3.5-year study. Who cares? I really want long-term reassurance. And we want, even with better CTA data and more of those. So this is just one study. What about additional studies? So Scott Hart, I'm sure everyone's familiar around Scott Hart, which is the famous CTA study in symptomatic patients that showed even getting the CTA done versus individuals who didn't get the CTA, there was an improvement. Of course, pivotal role in getting into class 1A recommendation in the guidelines. But even in this study, if you look clearly, in univariate analysis, plaque burden by calcium scores or CTA, adverse plaque, which is high-risk plaque, obstructive disease, risk scoring, everything seems to predict the risk. Now, when you put them together, the only thing that predicts the risk right now is you have calcium, and how much? And why? This is a simple, rudimentary, crude, very easy marker of presence and burden of the disease. So if you just take that into account, even in these well-done studies, that's the only thing that will help you. And by the way, it doesn't mean that I'm not in favor of doing CTAs. I think so CTA provides a lot of value of non-obstruction and FFR and many. But if you're looking for risk, the calcium score alone suffices. But in spite of that, I did review this paper from Scott Hart that eventually got published, and I was very supportive. The authors come back in another paper and saying, well, patients with 0 or minimal calcium score have a good but not perfect prognosis. This is kind of the feedback we keep on getting year after year, conference after conference, paper after paper. And we are content that CTA is the only way or the way that should be done, at least in this patient. So the question is, I just want to ask and take us a step and wait, but why? So how do you get to that conclusion? What was the rationale for you reaching this conclusion in your paper? And the rationale was, yes, you miss few MIs. So in this study, about 41 individuals had an MI in the next 3 to 4 years, and 4 of them had a calcium score of 0. So obviously, 10% of all events are happening in a group that you and I might have been reassured that's pretty low risk. So what's the alternate? Let's do a CTA because you're missing some plaque, some non-calcified plaque, maybe obstructive plaque, et cetera, et cetera. So what's the event rate if you had a normal CTA? It's only 1 event less. So in essence, 9.7 to 7.3, and if you truly want to see this is not by chance, and Safi can correct me with sample size and study parameters, this is almost you need a sample size of 4,200 individuals to show a difference of this one individual that was it. So in all honesty, when you start looking through this and going through debates at ASNC and SCCT, that doesn't make sense to me. In all honesty, like, where are we going with this? Is it about the data, or is it more about our practices and our affiliations and our beliefs? Because the data doesn't sound to be pointing in that direction. And when we're talking about long term, if you go back to this study in UK, about 3,000 patients symptomatic with CT and calcium, again, the same thing, half of them you could have avoided with a calcium score of 0 because the negative predictive value of rule out was again 99.5%. But when you follow these individuals beyond 3 years and 4 years and say, what's the risk of having a coronary event? In 13-year follow-up, max about median about 7 to 8. 0 individuals died of any coronary event. Again, extremely reassuring again and again, short-term, long-term, diagnostic performances, ischemia, you name it. And clearly, if you look at the authors, like me, they're saying, why are we doing this? Is there a need for further testing when the calcium score of 0? Now, there are guidelines and there are practices, and we do a lot of things because that's what we do. And that's fine, but I think we should all at time take a step back and question our practices. Because unless and until we do, we'll continue the same thing. And this is an opportunity, as I said, for a lot of the young imaging outcomes, faculty, as well as postdocs to think about how can we incorporate some of these items. Now, again, clinical trials are needed. Of course, that's a great opportunity for everyone. But there is some clinical trial data from my dear friend Kuhn Neiman, who was the last SCCT president and at Stanford right now. They did a PROMISE-like study, CT versus stress testing. But they were more pragmatic. They actually, in the CT strategy, they added calcium testing upfront. If it was negative, calcium score of 0, and the pretest probability was less than 70%, they avoided downstream CT angiogram. So what they found, that in all patients with less than pretest probability 70, they ruled out CAD based on 0 calcium score. During follow-up, these patients didn't need any further testing. No adverse event happened. And actually, as compared to, of course, it was a smaller study, as compared to the PROMISE, where you didn't see any differences in outcomes based on this ischemic versus an anatomical strategy, the cardiac CT strategy had a lesser adverse outcome, especially around the need for testing. For example, in functional testing, 42% individuals still needed some testing, the same amount of cath and also both. So this was the main difference leading to cost saving too. And again, Kuhn Neiman says that which is a rationale thought. It's an excellent negative predictive value. Its incorporation is justified in the CTA logarithm. Our results shows no indication that if you and I implement a calcium scan in a low intermediate patient as a first test, it's unsafe. So again, this is a clinical trial. This is not real world evidence. This is not prospective. Of course, we need more. But again, it's a start. We need to start acknowledging all of this data. Now, this is the hardest part. I've just been talking about patients with stable chest pain. What about if they walk into the ED? This is kind of the one that I get the greatest pushback. There's no way in hell we're going to consider the power of 0. Why do you even want to do this? Do you want to have a suit? Do you want to miss that one person who's going to come back with that juicy, obstructive, exclusive, non-calcified plaque? I get. I've also been suggested that some patients who underwent CTO had a calcium score of 0, but that's a separate story. So where does this data comes back? The first data is really, if you walk back, was my introduction when I was at MGH doing the fellowship, was the ROMICAT-1 trial. It's a fantastic study, by the way. They took 400 patients. I helped with some of the recruitment. Of course, this is where my thought process about the power of 0 really helped. And say, we're going to do 64 CT slice on everyone. The endpoint is ACS during the hospitalization, and we'll follow them for 6 months. The beauty of the ROMICAT-1 was that all of the CTA results were blinded. So we recruited the patient, we got the CTA, we never told Dr. Pasha or anybody who's taking care of the patients what the results of the CTA. And by the way, there were tons of obstructive disease in that patient populations. Can we do that right now, where you have somebody coming with chest pain, you do a CTA, and it's blinded? Very interesting finding. It was a low to intermediate risk for only about 8% patient had an ACS during the index admission. We followed them for 6 months. By the way, if you didn't have ACS index, none of them happened in the 6 months. So clearly what the study showed that if you had no plaque, your negative predictive value was 100%, or all patients who had ACS had no plaque. Now, unfortunately, in this study, we didn't do the calcium testing. And the rationale for the not doing the calcium testing that could have informed us side by side was this is increasing the radiation dose. So that was my whole, I'm saying, why are we not doing this? But again, they had non-calcified plaque and not. So by the way, if you look at that data, there was only one patient that on the non-contrast CT, they were unable to see a calcification in the corneas. So even if you think that is accurate, that's a 99.7% negative predictive. By the way, if you have minimal amount of calcification, as we have seen in Miami Heart Study, with the calcium score of 1 to 10, about 10 to 11% of the CTA comes back completely normal because it's unable to pick with the contrast those minimal amount of calcification. So I don't know where this ended up. Then, of course, we had the Akron study, we had the ROMICAT-2 that were more randomized. And they said, okay, fine, 1,200 patients, let's try to put data together. 65% of these patients who are coming to ED had a calcium score of 0. There were 4 events in all of them. The negative predictive value was 99.5%. But this wasn't enough. And why is that? Because your 95 confidence interval is overlapping the safety interval of 1. Hence, we should continue doing the same thing all over again and again. Fine, if you go to a larger study by the current SCCT president, Brian Goshara at MGH, they found in 800 patients, if you want to rule out obstructive disease with TIMI risk factors, it's almost 99.7 and ACS by 100%. And I couldn't agree more. We keep on having all these experts in their papers showing the data, how well it works, conclude that in the conclusion because you have to be objective, but when you are having discussions and debates and when you are having part of the guidelines, that goes out of the window. But clearly, Brian says that it's an excellent negative predictive value. It should be used. But again, I think so the message has not yet come across. And of course, we also then said, let's do the largest study. So when I was at Baptist Health, we took about 6,000 patients with CTs coming to the ED, almost 5,000 by the end. Again, 56% had a calcium score of 0. 1 in 20 with a calcium score of 0 had any plaque. Less than 1%, about 0.5%, had obstructive disease. Less than 1 in 200 needed revascularization. So 99.3 negative predictive value to rule out almost, you need to do 264 tests additional to find one where you may do some revascularization or additional test. And so, there's been a lot of ongoing debates, and my discussion has been clear that it should be used for advanced gatekeeper in the emergency, but the feedback is, again, do the finding lead you, and I want you to ask the question yourself, to use calcium alone when the calcium is 0. Would you do that if you were in that situation? And again, the answer that I'm getting for the last 15 years is again the same and the same. The overall rate is very low, but not 0. What has a 0 rate? Just because the calcium score is 0, is that an annotation that we have to? I'm just thinking out loud. What's the issue? I think it's not enough. So that's what the feedback I get from world-renowned experts in these discussions. So let's play a game. Test A or test B. You're in an ED, and test A, it's going to come back normal 91%. And if you send them back, about 1.2% individuals would have a MACE in the next 6 months. The other test, if you do it's normal, it's 65%. And the MACE is 0.3. Let's assume the cost, logistics, issues, availability, everything's the same. Who would choose test A in this situation, if your idea is to rule out in a low to intermediate individuals? No, seriously, test B. So at least few heads. What about the others? We'll just wait for the results. All right, so again, few more hands for test B. And then again, I really want to thank Faisal, young Faisal at that time, still young, but younger, I would say, for this amazing study. In all honesty, I remember meeting Faisal the first time in 2012, and his 2010 study I was so impressed I had to go and shake his hands, because this was an amazing study. This with Faisal and John, where, look, 1,000 patients coming to our own Houston Methodist ED, ruled out negative EKG, negative troponin. I'm not really sure how you got all of them to have a calcium test at that time, but that was amazing. Yes, and Dr. Memarian. So thanks to Dr. Memarian. So if you look at calcium score of 0, only about 8.8% of them had some abnormal stress myocardial perfusion imaging. So these are the patients you're going to do the stress test, send them home, whatever you're going to have. And yes, 32 patients had MACE during that event in 7-4. So again, if you look at a normal spec within an acceptable range, 1.2%. This is not even real-world evidence. This is Houston Methodist evidence. Now, what about calcium score of 0? It's 0.3%. So, this, and I remember it was 2012, and it was a debate with Joao Lima, who's my mentor, by the way. As a part of the debate on that ASNIC in Baltimore, he asked me point blank, Khurram, how would you sleep at night sending somebody with a calcium score of 0? And I said 4 times better. Really. So the question really is that this is not even clinical trial, real world. This is our own data. So Faisal, where are the calcium scores of 0 protocols in our ED? As I said, there is evidence, there is practice, there is guidelines, but we have to start thinking. And if you put things together for all the other ones, especially for a negative predictive value, it's better than an MPI and a stress echo. So why are we not employing that? Because I assume that if all the other tests, like stress echo, MPI, stress MR would have that, just to add a little fun out here. ASC, SCMR, and ASNIC would be jumping up and down. And you will be seeing on Twitter all day, justice for CMR, nuclear all clear, stress echo every day. Just kidding. One of the key things is there is no advocate for a calcium testing. Clearly, we have advocates for all the modalities, SCCT, mainly for CTA. But again, data, evidence, population, value-based, we all have to think because we're all in this together. And then again, how could we not end up without a meta-analysis again with Safi joining us? And we said, okay, now let's do even more contemporary meta-analysis that was just published for acute chest pain and stable chest pain. Clearly, you can see the event rates in all the study, including facils, in the acute chest pain and in the non-acute chest pain. The annualized event rate is literally 0.005, which is extremely low, and we clearly are coming back again in a value-based. That's where you guys will spend most of your time, if not in the next 5 years, but definitely beyond that. Delivery model. Calcium testing as a gatekeeper for advanced imaging is going to be extremely useful. And of course, we have suggested you don't have to accept, but acknowledge the power. And in our latest one, you can minimize your losses and maximize your gains by a simple algorithm. Of course, you don't want to do that if you're a high pretest probability. Somebody walking in with an unstable angina, you don't want to do that. If somebody is with a typical chest pain, I walk half a block, severe chest pain goes in. I don't even do CT or stress. I send them directly to the cath. Dr. Shah is not here. He will verify all of them have LAD hanging by a thread. If they're aged below 50, if you're unsure, but most of the data is pretty reassuring now, I think so we can move. And if you have elevated troponins, you don't have to do that. But if you have none of those, and these are the majority of the patients we see in our outpatients, even in our ED, a calcium testing suffices, and if it's 0, that's all you need. And then again, I think so the advocacy is going to lead power of one step at a time. Of course, we advocated that at least start acknowledging. Although the latest chest pain guidelines doesn't go enough, I think so at least it's pedaling slowly into this. For the first time, they're saying, well, if you're low risk, the calcium score may be enough. And it was interesting to see the acknowledgement coming from Martha, Roger, and all of those guys who are in the acknowledgement of the power of Zevo is pivotal in shifting towards more value-based healthcare landscape, something we advocated almost a year back in our editorial. So, it's not only about science, it's a lot of advocacy of all of us coming together, understanding how does the guidelines get implemented and what do we need to do for our own systems. We can keep on waiting for others to make changes or take the lead. But the question is who's going to take that lead? And I think we have an amazing, amazing opportunity out here to lead from the front, create the knowledge, and become the North Star for everyone else. So, as I said again, we will need RCTs. And why is that? Because I was asked the question this morning, and because the bar has been set higher. You didn't need RCTs for stress echo or stress myocardial or ETT, but now for CTA we need it. And now I think we need those type of RCTs here, which can easily be done in our integrated model. For example, a simple study which I can guarantee you would get you a Carrier Development Award or an R01 or even a Carrier Development Houston Methodist Award, just taking individuals who are having stress myocardial perfusion imaging and randomizing them to continue doing that, what is it, calcium testing, and if it's 0, do nothing. And follow them for 30, 60, 90 days for events, safety, cost. There is a lot of interest. I would love to do that. In all honesty, at this stage, I've moved on to so many other things, which is more around population, big data, but this is an area ripe for early career folks, and especially who are at Houston Methodist. But I would say till then, the truth shall set you free. If you have a calcium score of 0, remember it rules out obstructive disease with a negative predictive value of 97 to 99%. Rules out ischemia, no extra risk if mild ischemia. There is 0 risk, or at least as low as it can get, in even up to 13 years. There is 0 events with the calcium score in real-world situations that you have seen in these individuals. Even in RCT, It rules out disease and ACS by almost 99 to 100% better than the stress myocardial perfusion imaging and a lot of other tools that we employ. So if anyone else comes back again to you guys and gives you a notion that calcium testing is dead on arrival, just let them know it's alive and kicking. So we are in, as I said, we are in the second end stage of the truth. First, it has been ridiculed, it's violently opposed, but I truly believe by the efforts of many in this room, if you are inspired and you can take on to this, you will create the evidence that it will get into the guidelines. So thank you so much again for listening to this long term. Thank you. So, Deepan, when are we going to put the calcium testing in our chest pain algorithms? My question. I'll start.
Yeah, Khurram. So one, thank you very much. I appreciate this provocative lecture. And I think you did it very, very nicely. You've shown clearly in the asymptomatic patient population, calcium scoring is the test of choice for risk stratification. I think before we move to the ED population, what I'd like to see is employment of this strategy in the outpatient setting, in the patient that presents with stable chest pain. And I'll ask you today, in 2023, in your clinic, up on Smith 19, patient comes to your clinic with chest pain, low pretest probability, what's your treatment paradigm?
It's a CTA for now. And I've said that's the implicit bias. Let me tell you why it's not there. Guidelines. I couldn't agree more. There are no studies. It's not an institutional approach. The risk is not zero. And I'm very clear and front up with the patients as myself why I'm doing it. But we cannot put that on data. So what happens when you go to the guidelines, the pushback is there is no data. There is data, there is no advocate. Unless and until we get into those guidelines and unless and until we do some more RCTs, there is no reason. It cannot be that I am the only one who's sending back patients with the calcium. It's a collective effort. If we are ready as a group and the Houston Methodist DeBakey policy is based on the evidence, this is our protocol and we will adhere to that protocol, then I will do it with everyone.
Yeah, because I think...
But that is the problem.
Yeah, but I think
So
there's two pathways that we can look at. One is the stable CAD outpatient.
Yes.
And then the other is the ED chest pain.
I agree. We should start with I couldn't agree more. We should start with the stable ED. We should start with the pilot study for 100, 200 individuals who are coming where we can randomize them before even coming to this strategy to look at how safe it is. There is clearly clinical equipoise. There is no data that suggests that these individuals are a high risk. Actually, the other way around. We have our own institutional data. So yes, we have to find the courage to do a study. The question is, again, I point back to everyone in my imaging community, do we have the courage to do a study like that? Yes, that is all.
It is time. It truly is time. I think we have plenty of data to tell us. Somebody has to hold our hand. Yeah. Not our hand here necessarily, the hand of the community, to put something together like this. And I think it's even more urgent in the ED population. The ED population, similar to what Faisal and John Mamarian have shown. Every ED population in the United States, it is different than the ED population in other countries. So the incidence of coronary disease and, you know, an event down the line is very, very, very low. So, I mean, my approach to this is going to be a multifactorial. Calcium scoring would be part of it. You have risk. You have to take a look at the risk of the patient, what the EKG is like, what the troponin is like in the ED, in addition to what a calcium score. So just imagine how quicker the patients would be attended to. And you know, it is safer, conceivably, still safe, meaning to send them out, meaning that you don't need the urgent stress testing, CTA, and everything else that you need to do in those patients when they come in, because you're looking at multiple factors. And here you're looking for obstruction or near obstruction when somebody comes in with chest discomfort, mostly at rest. I mean, that could be done almost simultaneously, to tell you the truth, but somebody has to take.
I can tell you this could be not an easy, a very competitive career development award for Houston Methodist internally, as well as a K award for that.
You got a challenge.
Yeah,
All right,
but we need folks to take the challenge. Mahmoud?
Khurram, very, very elegant talk. Thank you so much. So the question I have is, unfortunately, stress testing is a very lucrative business. People can get annual, even some of them semi-annual stress testing. And as you said, a lot of them really do not have disease. So the two questions is, when will major carriers, insurance carriers, whether Medicare, Medicaid, or private, will cover calcium scoring? Some patients are saying, I'm paying $600 for my medical benefits. Why would I pay an extra $140? That's number one. But number two, in your slide, how come the U.S. Preventive Task Force feels that there is no sufficient evidence to advocate for calcium scoring, especially in people, let's say, in that intermediate risk based on the pooled cohort equation? So where do you put that into perspective?
I'll start with the second one. That was based on, because they didn't believe that the reclassification with the calcium was enough. They specifically mentioned my paper, highlighting the fact that, yes, it lowered the risk where they didn't need it, but their thought was, that's not all alone, that's enough. In our view, that was the main thing, that it reclassifies almost 50% of those individuals, but how they look at that. So again, preventive, their second thing is there is no clinical trial. They're still in the screening mindset. So, screening is, you're not candidate for a therapy. You do a test, you find high risk, you treat. Now, whether that helps or not, the latest context of a calcium testing is the decision-making. Most of where it needs to be done are already candidates. So you need to help them whether you need to commit or not. So that's one. The first one, it's a challenging one. In all honesty, I don't know. SHAPE, many other societies, SCCT, I think ACC needs to do more. I don't think ACC has yet been as supportive, vocal support, because they have. And again, I can understand they have a limited advocacy agenda and where they want to focus. And there are many priority things where already things that are covered, you want to make sure they remain covered at the same cost and prices, where that's an easier option rather than saying we need to cover for a $50. Now, the price is very low. Most of the places, apart from us, can do it for $50. In Ohio, they're doing it for free. So I think so we need to just push that and at least get the costs out to a range where most of the people can afford it.
I mean, another facet that I know you didn't touch upon because it's not the topic today, but since we're talking about detection of ischemia and thinking about prognosis, I want you to keep in mind the false reassuring sense of a normal stress test. You always hear patients, their friends or themselves or whatever it is,
I don't know.
Oh, doc, I just had a stress test and it was normal. And I come in after about a month or so, or 3 months or 6 months, with an acute myocardial infarction. How come? Remember also that the incidence of acute myocardial infarction, acute coronary syndrome, from burden of disease is 2/3 outside the significantly stenotic artery than in the significant coronary artery. Also remember, in risk stratification, the data from here, from Sumin Chang and John Mamarian, in addition to many others, looking at specifically normal functional stress testing. The prognosis of somebody, if somebody comes in and has some risk, but their stress test is normal, you can risk stratify them based on load of atherosclerosis by calcium score. So your best prognosis is a normal functional stress test and a calcium score of 0, and it gets worse and worse and worse the higher your calcium score. which tells you that I have atherosclerosis somewhere else. It's not functionally significant at this time, but it may come in as an acute coronary syndrome. So there is risk of what happens down the line. There is, here we're debating somebody who comes in with chest pain, right? Somebody with chest pain, what do you do, and should you be, how can you be as a gatekeeper? Keeping in mind that you are the clinician ultimately, and if there are some signs and symptoms, you can't just go by dichotomizing everything that you see, right? So, keep those in mind, because it's important when you look at patients. You have to look at them prognostically, not only one test that I do, what's their burden of disease, what's their progression of disease down the line. And, functional stress test may tell you something now, but it doesn't tell you about burden of disease.
Yes, Faz.
Khurram, very nice talk as usual. I have a question and a comment. I'll start off with a comment. Definitely, would love to see a trial as you have proposed here at Houston Methodist. I think we would learn, of course, a lot, and especially when we could compare calcium scoring with just a simple blood test, such as a high sensitivity troponin. And we may learn we may not even need a calcium scoring in the acute ED population, but something we can learn. But my question to you is, let's say you perform this trial and you get 1,000 patients. That would be an amazing number, right? In a cohort where the event rate is extremely low, and we would be, what would for ED not to have any events would be 60 days, 90 days follow-up, My question is, would that really move the bar for the public to embrace this technology without having the need for people saying, well, we need even more randomized trials because this is just one study of 1,000 in a low event rate group?
I think it will pave the way for the acceptance within the guidelines. I think so that's going to be a big step. My thing is, it's not going to be a superiority, it's a non-inferiority study. So 1,000 plus minus, with all you need to show is 30, 60, 90-day safety data. And by the way, the length of the stay would be significantly lower. The chances that you may be going to the cath labs would be slightly lower. But again, if you have a calcium, so 60% of the patients may not need a CTA. So that's a huge cost saving, time saving, cost saving. Now, if that approach can allow you to be safe in 30, 60, and 90 days, I think so that's all we need. That's an ED one, but I think so we should start with the stable. We have a much easier low-hanging fruit there. Yes, Mahmoud.
Just want to make a comment that, we always make the argument that there's no clinical trial for calcium. And I really disagree with that, because so many things that we do in clinical practice have a class 1A recommendation, like risk scores, that have never been used in a clinical trial per se. I think there's like a wealth of data from observational studies and real world data showing that calcium can reclassify a lot of people and has good risk discrimination even when you add it to risk factors. And we do all these trials, multi-million-dollar trials, that we show a 2% absolute risk reduction, whereas we have a readily available tool that sadly is not reimbursed. So the argument that there's no clinical trial, I think, really doesn't have much muster in my opinion.
I'm with you. But at the same time, reality is that will help move. Now, of course, institutions can make their own protocols. I can tell you British Columbia, because of the contrast shortage, they actually started doing calcium testing for chest pain patients, and if it was 0, and I was told that it was less than 10, they wouldn't go ahead with the CTAs. So that was happening even there. Intermountain has incorporated some of these protocols for their PET testing. So yes, localized institutions can create their own protocols, but we need to push the envelope in the guidelines. The problem is in the guidelines, unless there is an advocate who can point to these data where you can say, well, you got these tests a class 1A on these criteria, this meet a criteria. Who's going to advocate for that? That didn't happen in the chest pain guidelines. Finally, it got the acknowledgement. But I'm optimistic. There is a lot of data coming from Europe. on the safety of the calcium score of 0 in the CTA setting in chest pain from the Denmark study, I truly believe that the next set of the guidelines, when and if they happen, will have a big role, potentially at that time. But again, for early career folks, I think there is huge rationale, there is amazing significance, it's an innovative protocol that will change practice. And the environment, this is among the best environment to do these kind of studies. So I'm very excited if anyone from here would like to take a lead on those. Yes, Suman, last question. Sorry, Suman, I didn't hear you. Can you use the mic?
Yes, so great talk. My question is if we start this protocol, what group of patient you would exclude?
So
Meaning patient with
So again, the ones that we showed, high pretest probability, you should definitely exclude. Unstable angina, you need to exclude. So we'll start with stable patient, low to intermediate. In all honesty, if we do that without an established CAD, low to intermediate risk individuals, that is still the majority of the patients that get stress testing locally and nationwide. I think so that's the right population, as Deepan pointed out. We start there, and then you slowly expand as you get experience and confidence. So again, thank you so much again for allowing me to present this provocative idea. I hope we can take it to the next step. Thank you so much.